Hello, family, and welcome to the Prescription for Better Living podcast, where we discuss all things health and wellness in a hip and relatable way. I'm Dr. Hernando Carter, board-certified internal medicine physician. Yes, your primary care extraordinaire. And this is episode 33 of the Prescription for Better Living podcast. So welcome to episode 33. I want to give a shout out to our sponsor. That's Right On Time Physical Therapy. My man Cedric Cooper over in Ensley. Go on over there and check out Cedric Cooper, whether you're having some knee pain, some shoulder pain, elbow pain, neck pain, back pain, whatever it is. Even if it's not pain, maybe you're stiff. It's time for people to be working out. You're working out more and you need some help with your muscles being tight and stiff. Need to work on that range of motion. Go check out Right On Time Physical Therapy. Look, they are a Black-owned small business. They are in our community right over there in Ensley at the Ensley Health Club on Avenue D. You can check them out at rightontimept.com and tell them that Dr. Hernando Carter and the Prescription for Better Living podcast sent you. Also, you see what I got on today. This is some new merchandise that we are going to be rolling out for the podcast. So this sweatshirt says, "Living Better for My Children." So the concept here is that in our podcast family, we are all about a better quality of life, which is why it's called Prescription for Better Living. We want to live better lives mentally, spiritually, and physically. And that's what we're all about. So this sweatshirt is going to help be a reminder to you and your friends and family, be a motivator, and you'll be supporting our podcast. So we're going to have different colors. We're starting out with red, black, pink, and we're going to be taking pre-orders. So if you are following me on any of my socials, the Noop MD on Instagram, there'll be a pre-order link there. Hernando Carter on Facebook, a pre-order link there. And then, of course, on our YouTube channel where this podcast lives, Prescription for Better Living, there'll be a pre-order link there. So go on and cop you some merchandise so you can look good. It feels good, too. It's plush, it's soft. And you'll be supporting the podcast. And as a special bonus, I will be taking a portion of all of the proceeds and donating it to the Prescription for Better Living Scholarship. Okay. So you'll be looking good. You'll be supporting the podcast, but you'll also be supporting charity. We give tens of thousands of dollars in scholarships every year. We're starting a mentoring component with the Birmingham Health Career Society. More to come with that. And so your money will not go to waste. So episode 33. I thought for episode 33, we would put a bow on what we've been talking about surrounding healthcare insurance, right? Really Medicare and Medicaid. But in talking about Medicare and Medicaid, we really covered how insurance works in general, particularly how people access insurance. We talked about even private insurance. We talked about the healthcare exchanges through the Affordable Care Act. So I thought that this would be a nice episode to kind of put a bow on that module while we transition to another. And so today we're going to talk about some health care myths. So we're going to be myth busters today on our podcast. What are some myths you've heard as it relates to health care or going to the doctor or medical care? So Hernando, why are you going to be discussing healthcare myths? I'm glad you asked. Remember, we want to promote health equity. We want to reduce healthcare disparities. And one of the ways we need to do that is by helping our community overcome the hesitancy they have when it comes to seeking medical care. And we talked about just the history of what has happened to our people in the medical industrial complex, right? And I'm not trying to minimize that, because we've talked about the real injustices and atrocities that have happened. We've talked about social determinants of health. We've talked about healthcare disparities as it relates to racial disparities. We talked about the history of what has happened with medical experimentation. So I'm not minimizing any of that, right? But there are some healthcare myths out there that make people apprehensive, that make people not trust, right? And make people kind of skeptical about the care they're receiving. And so we're going to tackle some of those in this episode. So health care myths. Why don't you think about a healthcare myth that you have heard, or I can't even say a healthcare myth that you've heard, because until I cover these things, you may still believe that they're fact. So why don't you put in the comments, right down there in the comments, some reasons why you are skeptical about your health care, skeptical about your doctor, the doctor's recommendations. Why did the doctor keep trying to prescribe me medicine, right? So if you're skeptical about why the doctor wants to prescribe you medication, and if it's absolutely necessary, if you're skeptical about that, just say yes in the comments. Say yes, I'm skeptical. Also, what about your doctor sending you to different specialists and referring you here and there and yonder? Does that make you skeptical? If that makes you skeptical, say yes, referrals make me skeptical. And then, do you think that when your doctor makes recommendations for a medication or for a certain test or procedure, do you think that it's a money grab? If you think that, then put in the comments, yes, it's a money grab. Yes, it's a money grab. All right. And we're going to go through some of these myths. So what are some of the myths? I'll tell you, in my 15 plus years of practicing, probably the most common myth that I hear. And I'm fortunate that my patients feel comfortable enough with me to really ask me this question, because I think that a lot of patients think this, but they're not comfortable enough with their healthcare provider to ask this question. But again, I'm blessed for the most part to have great relationships with my patients, and they trust me. And so they sometimes will ask me things that maybe other patients wouldn't ask their doctor. So this is the most common. The doctor is experimenting on me and or using me as a guinea pig. Now, if you have ever felt that the doctor was using you as a guinea pig or experimenting on me, say, yes, I thought I was a guinea pig. I thought I was a guinea pig. Put that in the comments. Well, is that true? And no, it is not. Remember, we spent a long time talking about medical experimentation and the history of that, right? And so your apprehensions are well founded when we think about Tuskegee syphilis study, Henrietta Lacks. But remember, we talked about how those atrocities that happened led to a really robust check and balance called an internal review board, right? And so if you are going to be a part of some sort of study or a medical experiment, there's something called informed consent. So the doctors and the scientists have to let you know, this is the study, this is the experiment, right? They have to tell you all about it, the pros and the cons, every aspect of the research study. Then they have to get your permissions. You sign, say, yes, I'll participate. right? And then while you're doing the experiment, there is close monitoring by an independent set of people, right? And if there is harm, the study stops. If there's overwhelming benefit, the study stops. So there's checks and balances. But when you're going to just a regular doctor's appointment, you're going for your annual physical, or you're going for a routine checkup or to follow up on a medical problem like diabetes or high blood pressure, and the doctor is recommending adding a medicine, starting a medicine, adjusting a dose, they're not using you as a guinea pig. So when do people feel that their doctor's using them as a guinea pig? I'm glad you asked. When the healthcare provider has to adjust medications. That's a common thing. Well, why are they adjusting medications? Well, yeah, we have to adjust medications sometimes. I practice by the adage of start low and go slow. So, for example, if your blood pressure is elevated and I diagnose you with hypertension or high blood pressure, I may not put you on the full dose of medication that you need to be on right away. Well, why is that? Well, because I have to allow your body to have time to get used to the medication. The blood pressure medication is lowering your blood pressure. And people who have high blood pressure for a long period of time, once you start bringing that blood pressure down, it can make them feel funny. It can make them feel dizzy or woozy or lightheaded or tired or drained. And so it would be a very traumatic and dramatic thing for me to take your blood pressure from very high and put you on a full dose of medication and then drop you down to normal. You probably won't like me very much, and you probably won't take the medication again. And so it's a lose-lose. So I start low on a low dose. I'll see you back in a little while, see how you're doing, slowly increase it. I'm not experimenting on you. I know where I'm going, but I'm being very methodical about how I do it so that you can have the best outcome and experience possible. So adjusting medications. Another reason why people sometimes think the doctor is using them as a guinea pig is that if the doctor wants to change medications, right? Oh, he put me on this, and he said, well, no, now we're going to do this, and he didn't know what he was doing. No, that's not it. Every medication has benefits and they have potential side effects. And sometimes if you report a side effect to the doctor, you may not even know it's a side effect, but you say something to him or her about how you're feeling. They say, oh, it could be this medicine or that medicine. And every person doesn't get every side effect. We don't really know who's going to experience what side effect or not, because everybody's different, right? And so we make a decision based off of a bunch of factors with your input included, and we decide on a medication for this reason or that. Also, sometimes one medication, the first medication that we went with, may not be working well for you. It's worked well for others, but then we change it because it didn't work well for you. Now, there's a field in medicine that's emerging called precision medicine. And there's actually research going on right now. Look up and Google All of Us research. All of Us. All of Us is a national study through the NIH that is looking at things like your family history and your genetics so that we can come up with a tailored approach for your health care. So if someone has high blood pressure or diabetes or cancer We can run blood tests, look at your family history, etc., and say, based off of these factors, this medication is not right for you. We should go with medication B. Or this medication is good for you, but not at the normal dose. We need a higher dose for it to be more effective in you. You know what specialty is using that right now? Psychiatry. Psychiatry for many, many years have been able to draw blood and tell what kind of medication metabolizer someone is when it comes to using antidepressants. And so they can say, based off of this person's blood work, we should not use this antidepressant. We should use the other. Or normally we would say 100 milligrams of this antidepressant, but because of this person's blood work, we need 200 or 300. So it's not a novel concept, but we are trying to expand it to all of these other conditions, right? But until we're able to do that, we do the best we can with the information we have and with our experience, make a recommendation to you. And if it works, great, but sometimes we have to change. Well, what if my doctor recommends new meds like name brand medications? Clearly they're trying to experiment on me. Oh, no. When by the time the name brand medications have hit the market, they've gone through all kinds of clinical trials. We call those clinical phases, right? And they have to go under experimentation in the lab. And then once they leave the lab, they undergo experimentation in animals. And then once they leave animals, they go to humans who are knowingly signing up to participate in this research. Remember, informed consent. And then if it passes from that, it goes to a larger human study where more people are in the study. Again, informed consent. And then it gets approval if it passes all of that by the FDA, Food and Drug Administration. Then it gets to go out into the market where we can write prescriptions, but not before. So if we're recommending a new name brand medication, usually there's a very good reason for it. Like, for example, you've seen commercials maybe for a diabetes medication that's out there called Jardiance. Well, we know that Jardiance not only works well for diabetes, it works well for people with heart failure. It works well for people with kidney disease. So there's many indications for a lot of these new medications that we know work better and provide people with a better quality of life, keeps them out of the hospital, and helps them to live longer. So they're not using you as a guinea pig. The next myth: my doctor is pushing meds on me because they get paid for prescriptions. So if you thought your doctor was getting paid for prescriptions, put that in the comment. Yeah, he getting paid per prescription. I've had patients ask me that, and let me tell you, no. I don't get paid 1 red cent by anybody for the prescription I write you. I wish I did, because I'd be rich, baby, because I write a lot of prescriptions. But that is not true. There are no kickbacks. As a matter of fact, there in the law, in the federal law, there is an anti-kickback law. Look up Stark law, S-T-A-R-K. There can be no kickback. And if the government finds out there's an arrangement for a kickback, then people go to jail for a long time, have to pay back millions of dollars, lose their licenses. So no, don't get paid. Don't get paid. All right. How about referrals? My provider is referring me to this specialist because they get paid for it. You watch my back, I watch yours. Is that happening? If you thought that your doctor got paid for referrals, say Yes, he's getting paid to refer me. Say yes in the comments. But that's not true. That's not true. That again falls under that kickback, that stark anti-kickback thing. Now, what about labs and tests? My provider is ordering labs and tests because they get paid for it. Say yes, lab and test if you thought that. Put it in the comment. But again, that is not true. There is a lot of regulation surrounding self-dealing, right? And the government monitors us and insurance companies monitor us for what's called medical necessity. In other words, you got to have a medically necessary reason why you're ordering this test. And if there's not a medically necessary reason to be ordering that test, your insurance will not pay for it. That's A. Okay. B, if they pay for it and then find out that it wasn't necessary, they come back and they'll take the money back. Right? So we are trained to order only what is necessary, and we have to be able to medically justify why we want this test. This is why sometimes when you go to the doctor and your shoulder or your knee or your back or your neck or your head is hurting, and you walk through the door with this complaint for the first time and you want an MRI right there, and we say, no, we can't do an MRI right now. And you get mad at us because you think we're withholding that MRI because you watch NBA, and you watch the NFL, you watch the G League for the NFL now called college football, and you see they twist their knee or their ankle or something, and they rolling right to the back and getting an MRI, or they getting one the next day. Well, that ain't how insurance work, y'all. Them people got money, and they own the MRI. So they can get one whenever they want. So if you own an MRI, you can do one whenever you want. But if you don't, then we got to follow rules. And the insurance company says, before we'll pay for an MRI, you got to try A, then B, then C. And then if it's not getting better, then maybe we'll pay for the MRI. Back pain. You come to me for back pain, you're not getting an MRI the first time you see me, unless there are some concerning symptoms and I think something's really bad going on. Then I can order it, but then I have to do what's called a peer-to-peer. So I have to talk to a doctor from the insurance company and explain to them why I'm ordering this MRI kind of out of order. But for the most part, you come, I'm going to say, put some heat on it. Let's stretch. Let's try some Advil or some Tylenol. Let's go to physical therapy. Let's do all these things. So this weeks down the road. And if it's still no better, then maybe your insurance will approve an MRI with a lot of paperwork. So no, we do not get paid for that. Also, look, again, false claims. There's something called the False Claims Act. Look up False Claims Act. They have auditors. That these are people that start their own business, and what they do is they go around and audit charts and audit claims, and they get paid tens of thousands of dollars if they find even a mistake. And you know who paid them that tens of thousands of dollars? Not the insurance, not the government. The provider, the doctor, the nurse practitioner, the physician assistant. We got to pay them that money out of our pockets. So we ain't playing, y'all. We not gaming the system. We not guinea pigging you. We not trying to get rich off of prescriptions or tests. We're just trying to take care of you the best we can. So this has been another episode of the Prescription for Better Living podcast. As always, I'm Dr. Hernando Carter, board-certified internal medicine physician. Yes, your primary care extraordinaire. Look, if this podcast has been helpful to you, if it's blessed you in some way, I need you to do a few things. I need you to subscribe to the podcast. I need you to like, comment, give us 5 stars. But here's what I need you to do. I need you to share it. I need you to stand on the tallest mountaintop you can and scream to the top of your lungs, hallelujah. Dr. Carter is here. Until next time, Dr. Carter saying,